Alright, let's see how good of a decision I made last time by stopping and not going on. So the last one was 25 minutes. I seriously doubt that I could have gotten through the rest of this in just 5 minutes. But I'm not sure that it's going to be too terribly much longer. But we'll see what happens. So on this one, we're really going to just be talking about transfusion reactions and transplant reactions. Much of this, I am certain, is going to be a review, and as I'm looking at the slide, I'm wondering what on earth happened to my pictures here. But anyhow, let's think about this scenario. We've got a woman, and she has type A blood, okay? She's blood type A. When you think about her and her type A blood, what are the antigens that she has on the surface of her red blood cells? Okay, think about it. So if we all come up with it, she has A antigens. Alright? She's type A blood. She has A antigens. So then when we get to that next question, what antibodies against RBC antigens has her blood produced? So essentially she has A antigens. What kind of antibodies does she have? And this is where it gets a little confusing because we have too many antis in this statement. But she has anti-B antibodies, meaning if she's exposed to B blood, which have the B antigens, she will destroy it because she has the anti-B antibodies. So her body recognizes the A antigens as self and don't produce antibodies against it, but they will recognize the B antigens as foreign and will produce antibodies against it. So I think we kind of answered the next of what will happen if she's given the B blood type, or type B blood. The red blood cells in that type B blood have B antigens on their surface, so her anti-B antibodies will attack it and destroy it. So then the third question, this is the one that got all discombobulated with my picture, is what will happen if her blood, her type A blood, is given to a person who has type B blood. So it'll be just the opposite, right? A person with type B blood will have anti-A antibodies, which would attack the donated type A blood antigens and destroy it. What would happen if she was given type O blood? Well, since type O has neither A nor B antigens on its surface, they can't be destroyed. There's nothing that can be destroyed. So that's why the type O is the universal donor. Okay? So type A blood carries A antigens and anti-B antibodies. Type B blood carries B antigens and anti-A antibodies. Type AB blood carries both A and B antigens and has no antibodies, therefore it's the universal recipient. And type O blood has neither antigen, but both anti-A and anti-B antibodies, and therefore is a universal donor. This is just another way of going through the exact scenario that we just stepped through. I like this picture a little bit just because it has the percentages, so you can see there that type O blood is the most common, followed quickly or shortly right behind with type A, and then both type B and type AB are definitely more rare, but it's just another way of looking at the exact same thing that we've just discussed in the prior slide. So now let's talk about transfusion reactions. When we think about transfusion reactions, we know it's a reaction to the blood that the individual is receiving. And I know that this is fairly repetitive. You guys have talked about blood administration last semester, so we're not going to spend a whole heck of a lot of time going through the process of how you administer blood. But I'm sure you recall that from your blood administration policy, part of that is that you need to stay at the bedside for the first 15 minutes. And the reason is that in that first 25 to 50 mils, or approximately that first 15 minutes of the transfusion, is when most of the reactions are going to occur. Is it to say that 30 or 45 minutes into the blood transfusion you can't see a reaction? Yeah, you certainly can at any point during that 2 to 4 hours or however long it is that you're administering that blood. But the most common time for reactions to occur is during that first 15 minutes. And I don't care what type of reaction you're having, if you are truly having a transfusion reaction, your very first step, always, without a doubt, is to stop the transfusion immediately. Even if the reaction is a fairly severe reaction, because I need to stop the causative agent before I go through my other life-saving techniques. When we talk about transfusion reactions, there are essentially 4 different types. You've got your hemolytic, your bacterial or pyrogenic, your allergic, and your circulatory overload. We'll talk about each one of those in a little bit more detail in a few minutes. When you have a transfusion reaction, not only is your first step to stop the blood transfusion immediately, but you also want to make sure that you notify the physician. That's urgent. You notify the blood bank, not as urgent, but still part of our process. And we need to make sure that we remember to keep the blood and the blood tubing, because blood bank will actually test all of that to see why we are having a reaction. Because remember, we cross-match blood so that we ideally do not have any possibility of having a reaction. So when we think about the different types of reactions, the first one that we're going to talk about is hemolytic. Hemolytic, just like it sounds, the blood cells are lysing or blowing up, bursting, whatever word works for you. Your typical clinical manifestations of this are chills and fever, urticaria, which is itching, tachycardia, chest pains or complaints of chest tightness. They'll often have shortness of breath or dyspnea, difficulty breathing. And a lot of times they'll actually have some lumbar pain. So when you have a patient who's complaining of back pain, that's actually something you want to pay attention to. Now, it could just be that the hospital beds are oh so comfortable and they're tired of being in it. But it could also be a more subtle sign to a transfusion reaction. They may have nausea and vomiting, and they may actually go all the way to lung crackles and hematuria, hypotension, and wheezing. By the time we've gotten to those should sound fairly reminiscent of anaphylactic reaction. So that is actually going into shock, and that is a big time problem. So you want to make sure that you're paying careful attention to the signs and symptoms so that hopefully you don't progress to that state. The next type is a bacterial, or sometimes called pyrogenic. When you see pyrogenic, one of the things that you should immediately think of is that they are hot or on fire, so there's definitely going to be fever and chills with this. They'll also be hypotensive, but they will have flushed skin, often will complain of abdominal pain and or pain in the extremities, with some vomiting and diarrhea. Can you see it does not seem nearly as severe? I do not have the anaphylaxis occurring that you do with that hemolytic type reaction. Now, allergic reaction is going to go more again to that severe reaction, urticaria with the itching, and urticaria, I'm sorry, I think I said that was itching. It's really hives, and of course hives cause itching, so I tend to think of those 2 words together. But urticaria, so hives, and pruritus, itching, swelling of the tongue, never a good sign, swelling of the face, never a good sign, and then difficulty breathing, edema, and ultimately shock. And then the last type of reaction that we can have is a circulatory overload. The title gives you clues as to what you would expect to see. They could have chest pain and tightness in the chest, cough, lung crackles, pulmonary edema. So essentially they're wet all over because they're in fluid overload. I know Amy and I both tend to like these pictures, so this is another one that I would encourage you to go ahead and take out of the PowerPoint and blow it up so that you can see just if these work for you, the allergic or the febrile, which febrile is often the same as the bacterial, and then the hemolytic. There is no circulatory overload because that's pretty basic. You guys understand those concepts by now. But when you think of the acute hemolytic reaction, this picture I also like. I'm not going to go through it step by step because you guys know how to read by this point, and you could certainly do so and pull this picture out. But acute hemolytic reaction is one of the more severe, so I think it is one of the ones that you want to make sure that you have a good working knowledge and understanding of, and how to recognize. Okay, so that's going to wrap up blood transfusions. Let us now talk about some of our transplant rejections, or host versus graft disease. We know that this is a primary immunodeficiency disorder. There are 3 main types of transplant rejections that can occur. The first is called hyperacute. The words kind of give it away. Hyperacute means it's really big, really bad, really fast. It's pretty rare nowadays because we actually do a much better job of matching the transplanted tissue with the host tissue. So ideally we're not going to see this, but what happens is that the individual who's receiving the transplants, their circulating antibodies are going to react with the graft, and this literally occurs within hours of the surgery. Um, the manifestations of what you're going to see are obviously going to vary to some extent depending on what organ or body part or tissue or whatever word you want to put there has been transplanted. So that function of that transplanted organ is obviously going to stop. And if you actually were able to visualize that transplanted organ, which ultimately you will because they'll go in operatively, that organ looks very blue, cyanotic, and very flaccid. So ultimately, the way we're going to have to treat this is we need to go back in and we need to remove that transplant because it is going to cause life-threatening complications if we do not. The next type of transplant rejection is called your acute rejection, and this is actually a type 4 hypersensitivity. It's cell-mediated, and it occurs about 2 weeks after the transplant. It can occur within days to months, but the most common time frame is about 2 weeks after the transplant. And what happens here is that the body mounts that immune system to attack the tissue in the donor organ. Again, it's cell-mediated, so we're going to be using our T cytotoxic cells for this. Your clinical manifestations are going to be organ failure again, possible fever, you may or may not, and oftentimes there is tenderness and swelling where the graft is. What am I going to do to treat this one? We don't necessarily need to remove this, and oftentimes they don't. They will just increase the dosages of the immunosuppressants, trying to suppress the immune response that's going on. They'll give steroids. Steroids will again immunosuppress. They will also take care of the inflammation that is going on. And sometimes they'll give monoclonal antibodies to again help aid in the hyperreactivity of the immune system so that it will leave this new organ or transplanted tissue alone. Then the third type of transplant rejection is chronic. This occurs months or even years after normal function. So essentially the individual receives a transplant and it works for all practical intents and purposes, and then slowly over time that organ will progressively start to fail until it has gotten total failure. This is actually what happened with my father-in-law. He had a kidney transplant and it worked fairly well for about, I want to say about 5 years is where that kidney was working pretty good. And I want to say in the last year prior to ultimate failure of that transplanted kidney, we did notice that kidney function was starting to deteriorate and urine output was almost non-existent, and he was beginning to look again like an individual who had chronic renal failure. While the family was actually on a trip to Disney World, he suffered a myocardial infarction that actually went unnoticed by all of us because he was prone to complaining a lot anyhow, so therefore when he was complaining of the symptoms of the MI, it was not terribly different than what he complained of on any given date. So the MI was not managed as aggressively or assertively as it should have been, and essentially that MI knocked out what little function there was to that transplanted kidney totally at that point in time. And if you think about it, it makes kind of sense. With a poorly managed myocardial infarction, perfusion was definitely affected, and the kidneys are one of our best indicators, or urine output is one of our best indicators of overall perfusion. So when we mismanaged the MI, we were definitely affecting the overall cardiac output within his body. And so at that point in time, that transplanted kidney, which had already started failing because of a chronic rejection, just totally wiped out at that point in time. So ultimately, when you're looking at this, we honestly don't know why it's occurring. We think it has to do with some kind of delayed immune response, but we're not entirely sure. The manifestations are going to be just as we discussed, essentially that there's going to be a gradual decline in the organ function, but ultimately there's no specific treatment. With him, he did go on another transplant list, luckily, for various reasons that if any of you want to discuss, I'll be happy to discuss. Just ask me at some point. But for various reasons, he luckily was never called up for that second transplant. But they never did have to go in and remove that failed transplant. At that point, since it wasn't such a hyperacute response, it was safe to just leave within his body. Alright, so that's going to wrap up this part, and I will come back with the last part of this section, or this podcast, which will be our immune disorders, the primary immunodeficiencies and secondary immunodeficiencies.